This lesson is about molar pregnancy. A molar pregnancy is a type of gestational trophoblastic disease where an abnormal fertilization and proliferation events leads to abnormal placental growth. So, instead of a normal pregnancy, it results in a cystic mass resembling bunch of grapes. You can see in this picture, this is a picture of an evacuated molar pregnancy. Histopathologically, it will look like bunch of grapes. Keep in mind, it is not a typical pregnancy. There is no viable fetus, and the complications are arisen from this condition. Before we dive into further details, we have to define a term called non-viable pregnancy. What is non-viable pregnancy? A pregnancy that has no chance of live birth. Like early pregnancy loss, by definition, is called non-viable pregnancy. Who is at risk? Let's see what are the risk factors and what kind of persons are at risk. The first risk factor is maternal age. If the woman is less than 20 or more than 35 years, she has high risk with the highest incidence in women over than 40 years. Teenagers and older women are more likely to have complete moles instead of partial mole. I will explain the difference between these two, complete mole and partial mole, in the upcoming slide. Now we are going to, we are discussing the risk factors. The second risk factor is prior molar pregnancy. If the patient is having a history of one molar pregnancy before, it increases the risk of recurrence by 1 to 2%. The third factor is diet. Low intake of carotene or vitamin A may be associated, but the evidences are limited. Now we are going to classify the molar pregnancy, and we also look the pathophysiology, how does it happen, and the pathology. Now, before I dive into the types, you have to just keep in mind these things. First is molar pregnancy is caused when there is problem with an embryo's chromosome. For each pair of chromosomes, for a normal person, you get one from your mother and one from your father. So you have 46 in all. But in case of molar pregnancy, both the sets of chromosomes, like two sets, like one is both the like both two haploid chromosomes comes from father. In case of normal pregnancy, one set comes from mother, like one end comes from mother, and second end come from father. But in case of molar pregnancy, both sets come from father. So there are two types of molar pregnancy. One is complete hyatidiform mole, and the other is partial hyatidiform mole. I forgot one thing. Molar pregnancy is also called hyatidiform mole. So how complete molar pregnancy result? A complete molar pregnancy results from fertilization of an empty ovum by a single chromosomes or a double, like a single sperm or two sperms, leading to diploid karyotype, typically 46XX. Now in 46XX, 22 pairs, it means 44 chromosomes are autosomes and 2 double X chromosomes are sex chromosomes. These two sex chromosomes have actually came from father. Like we can say all DNA is paternal. Why? Because the ovum was empty. And if it is fertilized by one sperm from the father, the sperm get duplicated. Like in the sperm X chromosome if present, then it got duplicated and have formed the complete mole. Now this karyotype looks normal, 46XX. This is the karyotype for a normal male. What differentiates it from a normal pregnancy is all the chromosomal material is from father. Now we have to look at the pathology. There are no fetal tissues or embryonic development. The placenta shows diffuse trophoblastic hyperplasia and generalized chorionic villi edema. In this histopathological image, you see like small grape-like villi. So grape-like cluster or grape-like structure is related to complete mole. Now we have a look at a partial mole. In partial hyatidiform mole, a normal egg is fertilized by two sperms. What? A normal egg. Like in a normal egg, chromosomes are present in one and is fertilized by two sperms, like 2N. In egg, 23 chromosomes were present, and in two sperms, total 46 chromosomes were present. So, after fertilization, it will create a triploid condition, like 3N condition. In 3N, you all know that there are 69 chromosomes. It can have like karyotype of 69 triple X or 69 XXY or 69 uh, like XYY. In complete mole, as I have described, there is no any fetal tissue, but in partial hyatidiform mole, you see some fetal tissues may be present, but they are abnormal. But keep in mind that this type is also a non-viable pregnancy. After classifying the molar pregnancy, let's have a look on the symptoms and red flags of molar pregnancy. Complete moles present with more severe symptoms due to higher HCG levels and more aggressive trophoblastic proliferation, while partial moles may be mistaken for a miscarriage. How does this present? You have to remember a phrase: too much, too soon. The first symptom that you will notice is uterine sized, like a rapid enlargement in case of complete mole. What you see? You see enlarged size of uterus in case of complete mole, while in case of partial hyatidiform mole, it can be smaller than the expected. The other symptom is bleeding, most common symptom occurring in almost 90% of patient. Dark brown to bright red, too much bleeding is seen due to separation of molar tissue from the uterine wall. As I have already described that the fetal tissues, which are actually molar tissues, get implanted in the uterine cavity and there they proliferate. And this bleeding is due to separation of these molar tissue from uterine wall. The third condition, the third symptom is severe vomiting and nausea. This is related to higher HCG levels because HCG levels are sky high in molar pregnancy. The other symptoms that are rare but can be present in molar pregnancy is early preeclampsia, like less than 20 weeks. Most common time for appearance of symptoms of preeclampsia is during the later stage of pregnancy, 37 to 38 weeks, and preeclampsia have symptoms like high blood pressure, swelling of hands and feet. The third is protein in urine. These are all are the symptoms of molar pregnancy. The one most rare case is hyperthyroidism. The patient also show symptoms of hyperthyroidism like tremors, rapid heartbeat. Why this hyperthyroidism happens? Human chorionic gonadotropin, that is HCG, can mimic thyroid stimulating hormones TSH due to structural similarity. Because HCG have structural similarity with TSH, it actually mimic its function. The structural similarity let it bind to TSH receptor on thyroid cells, leading to increase in thyroid hormone. These were all the symptoms and red flags for molar pregnancy. Keep in mind that these signs and symptoms appear in the first trimester or in the start of second trimester. Let's discuss the diagnosis. The diagnosis is based on ultrasound findings and HCG levels. There are two tools, like first is ultrasound and the second is HCG. What you see in the visuals of ultrasound, like two tools are key, like two appearances are the key. In complete hyatidiform mole, you can see in this radiograph classic snowstorm appearance is found and you see no embryo, just sweetling cyst. Snowstorm appearance is the hallmark feature of complete hyatidiform mole, while in partial hyatidiform mole, you see some fetal parts but with abnormal placenta, like it resembling s- cystic spaces, like it resembles cystic spaces. The second factor that can lead to diagnosis is HCG level. Normal HCG levels are typically undetectable with the range of 5, produced by placenta after hormone gets implanted in the, after this is the hormone HCG, this is a hormone and it is produced as a result of implantation of fertilized egg. In complete hyatidiform mole, the HCG level is more than 100,000, like a million international unit per mole. During, in the first trimester, the peak value for HCG is less than or equal to 50,000 million international unit per mole. But in case of CHM, it becomes like 100,000s. In case of partial hyatidiform mole, the levels are elevated, but lower as compared to complete hyatidiform mole. Now, these two findings are like very important, but we have to always confirm histopathology after evacuation. We see trophoblastic cells leading to swollen chorionic villi. Now, in the last subtopic, we will discuss how we can treat this condition step by step. Management is straightforward, but very careful and precise. A management of molar pregnancy focuses on evacuating the molar tissue, preventing complications. The first technique that is used in evacuation is suction curettage, and this is the gold standard for treatment. In suction curettage, a thin tube is inserted into uterine through cervix. A suction device is then connected to the tube and it is used to remove the tissues. This is called the evacuation by using suction curettage. You can see in this picture that the tube is inserted inside the uterine cavity and a suction device is placed for evacuating the molar pregnancy. You have to avoid medical management because it can increase the risk of hemorrhage. The patient is already suffering from heavy bleeding. What does misoprostol do? It is an OCP and it is used to induce miscarriage. After the evacuation, what should be the follow-up approach? Weekly HCG levels. You have to monitor weekly HCG levels for 3 weeks. Then you measure monthly for 6 to 12 months. Keep in mind that contraception is mandatory, no pregnancy until HCG normalizes. Patient does not go for a pregnancy until HCG normalizes. She had to wait 6 to 12 months after HCG normalizes. The third treatment method is chemotherapy. If HCG levels does not drop, then we go for the chemotherapy. For low risk cases, we use methotrexate and it has 90% of cure rate. For metastatic disease, we go for EMSU regimen. What is EMSU regimen? In this regimen, on the first day, we give etoposide, methotrexate, actinomycin. On the first day, we give three drugs, and on the day 8, we give cyclophosphamide and oncovin. Now, after the treatment, what we can expect from the patient and what can be the prognosis? The prognosis is good, but 1 to 2% recurrence rate, almost 90% of the pregnancies give result, they have proper cure rate if proper follow-up is provided. For future pregnancies, we just have to wait until the HCG levels become normal. This lesson is about molar pregnancy. A molar